Now, has anyone come into the room since the devices were first handed out who might not have a device? If so, could you put your hand up? So that's anyone with a light blue or dark blue lanyard without a voting device. Okay, could my staff please distribute them to the people with their hands up? And just as a very quick tutorial while you're waiting to receive your devices, if those who haven't voted yet could just listen to me and not talk. Dr. Parker. It's number 1 in the affirmative, number 2 against, and number 3 for abstain. So wake your little devices up, they'll be sleeping. And once the first motion is put to you, you'll be able to start using it. Okay, so that covers off on that. Now we're still tweaking how we're approaching this. So we are going to now bring the mover of the motion up to the podium, and they will stand here to address you at the risk of not being able to get them off the podium, but the chair will make sure we can do that. Otherwise, the same rules will apply, 5 minutes maximum for the mover of the motion, no more than 3 minutes for any other speaker, and a 3-minute right of reply for the mover of the motion at the end of the debate before the vote is taken. Hopefully that's all very clear.
Right, thank you very much. So the next topic, e-cigarettes as a harm reduction measure. The draft motion that our AMA notes that current tobacco control measures have not changed the high rates of smoking in marginalised populations such as people with severe mental illness or Indigenous Australians, and supports the controlled introduction of e-cigarettes as a harm reduction measure. That's the only time I'll read the motion. It's moved by Steve Kisley, seconded by Gary Galambos. Welcome, Steve.
Hello, good morning. So Australia has made huge advances in terms of reducing smoking. Only about 13% of Australians smoke now. But this disguises several serious problems. Rates of decline are actually plateauing, and in fact in New South Wales last year it went up, the prevalence went up to 15%. And the benefits haven't extended to marginalised groups. 50% of Indigenous Australians smoke, 70% in some Northern Territory communities, and up to 90% of people with schizophrenia smoke. Most trials of medications actually exclude people with a psychiatric diagnosis as entry criteria. And in terms of smoke-free wards, the time to relapse on discharge from a smoke-free ward for a psychiatric patient is the length of the time I'm speaking to you now, 5 minutes. So why are we not considering e-cigarettes as a harm minimisation measure? They are legal in the UK, US, Europe, Canada and New Zealand. Observational studies by the Society for the Study of Addiction have found that 6 million people have quit in Europe thanks to e-cigarettes, and 9.2 million reduced their consumption of tobacco. In the US, smokers who used e-cigarettes were more likely to successfully quit. The evidence from both the UK and the US is that as e-cigarette consumption has gone up, tobacco consumption has gone down. Controlled trial data are limited, but they do seem to suggest that e-cigarettes are at least as effective as nicotine replacement therapy. The Public Health Agency of England, the Royal College of Physicians of the UK, the Faculty of Public Health Medicine in the UK, the US National Academy of Sciences all back the use of e-cigarettes as a harm minimisation measure. Even the Royal Australian New Zealand College of Psychiatrists back it. Only in Australia are they illegal. In the ACT, sitting in this room, I could be fined $30,000 for possession of a nicotine-containing e-cigarette and potentially jailed for 2 years. This is for a delivery system that's 95% safer than tobacco. UK and US evidence is based on up-to-date science. People talk about the NHMRC guidelines. They're actually a flimsy document of 2.5 pages long that actually quote the AMA guidelines, which then quote the NHMRC guidelines. You have this circular argument where the AMA quote the NHMRC and the NHMRC quote the AMA, but it's not actually backed by a critical appraisal of the literature. So what are the harms? Gateway theory, the idea that they're a gateway to the use of tobacco, is actually discredited in addiction medicine. We now talk about common liability. So people who are more likely to smoke may be more likely to experiment with e-cigarettes. But that does not mean it's a gateway. There's a danger of over-marketing. That's why this motion says it should be a controlled introduction. It should be at least as strictly as regulated as currently the use of cigarettes, which, as I said, are 95% more harmful. In the UK, vaping has actually plateaued around 1.5 million, and 99% of these are actually ex-smokers. Only 1% of vapers have never used a tobacco product before. The evidence is there. Why don't we heed it and help some of the most marginalised groups in our society stop smoking? We should have a policy, no smoker left behind. Thank you.
Thank you. Speakers to the motion, microphone 1.
I'm Wayne Hurdy. I'm a general practitioner from the Sunshine Coast. For my sins, I work in addiction medicine. Maybe a third, maybe half of my patients are addiction patients. I work with the schizophrenics, with the homeless people, with the Aborigines, with all these disadvantaged people we're talking about. And to me, it's a mystery why we even have to debate this. This is such a no-brainer. I just don't understand why we're wasting our breath on it. It is so obvious that if you can turn somebody from smoking something that's got 30,000 different chemicals in it, which are going to cause 10,000 different known diseases, and switch them over to something that might have 3, maybe 30 chemicals in it that so far are not likely to cause any diseases, why are we even have to argue it? It is so obvious. I'm sorry, I have to talk fairly strongly in favour of this motion.
Thank you. Microphone 2.
Good morning. My name is Jeff Bowden. I'm a respiratory physician based in South Australia. I'd like to speak against the motion. I think there are several valid points that were made by the previous speakers. Clearly, these things should be decriminalised, but I don't think we should be promoting the introduction of e-cigarettes. It's complex literature. There are uncertain effects. I think there are potential dangers still with formaldehyde, metals, other problems related with the e-cigarettes. I think other motions to look at decriminalisation would be appropriate, but the widespread introduction of e-cigarettes sends a bad message. Certainly the gateway effect, which the previous speaker said doesn't occur in US college students, does occur. There's increased uptake of tobacco. We're going to create a whole new wave of nicotine addiction if we support the widespread introduction of these devices. Thank you.
Thank you. Microphone 1.
Yep. Dave Manson from Western Australia. I'm speaking in favour of the motion. Most of those arguments are really not valid in the States. Since e-cigarettes have been allowed and legalised, there's been a marked reduction in smoking rates throughout the US. Similar has been happening in the UK. In fact, Australia is the only place that seems to be plateauing at the moment and will soon be overtaken by those countries, if not already. A lot of people talk about the precautionary principle, but there's nothing precautionary about substituting something that's 95% less harmful and we do this all the time for other drugs. It is absolute nonsense to keep on promoting basically a harmful delivery vehicle, kills millions of people a year, when we've got something that we know would be much less harmful and people will use in substitution for their other drugs. So I strongly support the motion.
Thank you. Microphone 3.
Hi, I'm Catherine Noonan. I work in public health. I'll be speaking against the motion. I think it's important to consider the Public Health England report in the context of the UK, where e-cigarettes are widely available, widely purchased and widely smoked, compared to Australia, where we're in a much more safe, unique position and can proceed with caution. But furthermore, the UK have always looked to Australia for our leadership in tobacco control. in the past. So the two theories that people who are proponents of e-cigarettes use is that it's less harmful, and realistically, yes, it is most likely 95% less harmful than smoking tobacco cigarettes. But the evidence, of course, is very, very short term. It's mostly based on in vitro and animal studies, which is the evidence that's been used by the Public Health England report. We don't have 70 years to follow up whatever cardiovascular implications there might be from e-cigarettes. But secondly, the other argument is that it's a way to quit, and the evidence there is actually equivocal that e-cigarettes are a quitting mechanism compared with other nicotine replacement therapies. So we actually have time to consider better evidence. But I do think the concerns around normalising the behaviour of smoking are legitimate, and the starting of smoking for young people, and that hasn't been proven in the evidence that it's not actually increasing people's uptake. But the other major concern that I have is that the tobacco industry are positioning themselves as part of the solution to a problem, putting them around the table and saying that they want to help, and it's a classic tactic of this industry, and potentially even contributing to misleading statistics that are now widely cited. But last of all, I just say that we need to consider in harm minimisation the three elements of harm minimisation, the first being harm reduction, but the second and the third are supply reduction and demand reduction, and legalising e-cigarettes and promoting them will not achieve harm minimisation in the round.
Thank you. We'll now take a couple of speakers from microphone 1.
Paul Bowers. I'm a paediatrician in the Northern Territory, and I visit a dozen remote communities regularly where smoking rates are 60% and continue during pregnancy with the results of small birth weights and contributing to these children's behavioural and impulsivity problems later on in life. Rowena Ivers looked at trying to reduce the rate of smoking in these remote communities many years ago, and several trials were implemented, and her main finding was that it has to be a whole of community approach. These are all small communities. In most of the communities I visit, the Aboriginal health workers and the remote area nurses will join each other for a cup of tea and a smoke on the front veranda of the community health centre, which doesn't send a very good message in terms of trying to get these, help these people get off. I really think there's a place for e-cigarettes in these communities. If the entire community becomes partial to them, then I'm sure we'll see the reductions that we need to see. And the previous speaker speaks very eloquently about what's happening in major centres, but in these smaller communities there needs to be some replacement for getting rid of cigarettes, and I think this is the perfect answer.
Thank you. Microphone 1 again.
Thanks, Bob. Gary Gilhope from Western Australia, and I think everything I was going to say was said much more eloquently back there from Western Australia. So just briefly, two things. One is be under no illusion, as was mentioned, this is the tobacco companies are behind this. Very, very big business. They are now doing huge business in the third world where they're, killing literally millions of people, and this is their way to try and get back into markets that, have been largely, they've been excluded. So all of what happened with cigarettes and their sort of the fight against that, that's happening now. So there's a lot of studies that are very dubious. Now the NHMRC did look at this very, very carefully, and they more or less said we should take a precautionary measure. We should stay out of this for the time being. The evidence is not there. And when you think about it, the biggest selling point is the fact that they're safer than cigarettes. If cigarettes had never existed, can you imagine we would ever think about actually putting this stuff into common usage, that we would allow people, young people, to start inhaling these medications or chemicals into their lungs? It would be a no-brainer. The evidence that this is actually good in terms of harm reduction, it's really not clear yet. So I think the obvious and sensible thing is that we hold off at this stage. We see what happens in the rest of the world. It may come to say that what is being put up by the speaker, it will come to pass. It hasn't come to pass now if you look at the evidence.
Thank you. Microphone 2.
Thank you, Steve Hambleton again. And look, I'm going to vote against this as well. At the moment, we're seeing $7 billion worth of global sales for e-cigarettes. And what are you inhaling? Nicotine, propylene glycol, glycerine and flavourings. And I absolutely agree, it's far less dangerous than tobacco smoking. But are we actually substituting tobacco smoking for vaping, or actually are we spacing out the smoking with vaping? Most people who vape actually still smoke. And I think we really need to think about what the quality of the research, and I think it is low quality data that we're looking at broadly, and I totally agree with the previous speakers. What else can you vape? Well, it might not be nicotine that you're vaping. Now, cannabis and cannabinoids are not very soluble, but there are soluble cannabinoids that can go straight in there. And so there are other things that you might think are nicotine vaping, but they're not. And I think that's another issue that we need to think about broadly. Is it helping stopping children from taking up smoking? Well, there's mixed evidence on that, and there does seem to be a pathway in the United States, but I'll be voting against it.
Thank you. Microphone 2.
Michael Gannon, congratulations, Steve, on bringing the issue forward. It's important the organisation is challenged on its policies from time to time, but I stand to speak against the second part of the motion. I just stand mainly to remind people of existing AMA policy, which is to support the NHMRC. In other words, to support the scientific evidence. There is clear astroturfing by big tobacco. There is millions and millions of dollars going to support allegedly grassroots campaigns. They are dishonest. We are very simply saying let's look at the highest level of evidence, and with all due respect to the committees of the College of Psychiatrists, etc., that's not the level of evidence that the NH and MRC demands. Britain, I have often spoken about my lament about the clouds of vaping steam and the shops that proliferate all around every high street in Britain. We do not look to Britain for tobacco control. Australia has led the world. This would be a retrograde step.
Thank you. Microphone 1.
Yeah, Ross Kerridge, Newcastle in New South Wales. I agree. I'm disappointed with the naivety of some of the arguments in favour of vaping and as a harm reduction measure, and be under no illusion. If we pass this, it will be in the media tomorrow. AMA supports the introduction of e-cigarettes across Australia. There will be no hedge words about as a harm minimisation measure. There would be nothing about under controlled circumstances. It would be AMA supports e-cigarettes. This is the tobacco industry coming again. We have led the world in tobacco reduction. We were moving towards endgame with tobacco sales in Australia, and now this has come back. This is hopefully their last hurrah, and hopefully we will stand up against it.
Thank you. Microphone 1. No, you're next, Rob.
Okay, Rob Parker, Northern Territory. I'm speaking in favour of the motion. Again, I reflect a lot on what my colleague Paul Bowett says. I can reflect again on my colleague from the Public Health Association. In the Territory, we've seen lots of campaigns with all the good words from the Public Health Association about what it's going to do. Nothing works in communities, and I mean, Paul's right. There's a heap of people smoking in communities, and immense damage in terms of their health, damage to others. And I think to be totally blocked, I mean, most of the speakers I see who have been here, to be frank, have come from the sort of leafy green parts of Sydney, Melbourne and wherever, without very little contact with the real life of Aboriginal communities and what it means, the really desperate issues about tobacco. Yes, you can put up the price, more money will go into tobacco rather than away from kids in other areas. It's a really bad problem in communities, it's a really bad problem for the Northern Territory, and to be totally blocked on sort of ideological grounds because of big tobacco or because it doesn't work in the leafy green areas, I think is a real problem. And I think we have to be a bit more creative in this space.
Thank you. Microphone 3.
Thank you, Chair. I stand because I'm so totally conflicted about this. It seems to me that on the one hand we look very unsympathetic to the deep and entrenched issues of addiction in both Indigenous and alcohol and other alcohol and drug addicted people. And on the other hand, we're trying to protect the rest of the Australian public against the potential growth of smoking. I don't know what the evidence is around the effect of e-vaping in these particular communities Paul's put forward, but it does appear to me that we've got a problem with the way the motion is worded, and we can't put an amendment. So I have to stand sadly against this motion because I think the public health issues and the way this is going to be portrayed in the media if it passes will be devastating. But I think that it absolutely behoves the Federal Council to have listened very carefully to this debate and realise that if we have a potential solution with vaping in particular communities, and we need to find a way through to make sure that that is possible. So I'll leave it there. Thank you.
Thank you. Microphone 4.
Thank you. I think one note of caution that we should remind ourselves of is that there seems to be a lag period in the onset of chronic disease and respiratory illnesses following exposure, such as to silica, asbestos, tobacco, etc. So that there's a long lag between the exposure and then the onset of disease, so that we really don't know what the long-term effects of exposure to the substances in vaping will be, but the lag period can be decades rather than certainly a period of months or years. So I think we should be careful before we endorse something where the long-term consequences are unknown.
Yes. Excuse me, speaker from microphone 4, could you identify yourself for the...
Yeah, I'm Dr. Langdon and I'm a paediatrician from Perth.
Thank you. Microphone 1.
Hello, my name is Dr. Paul Bryan. I'm a GP from Brisbane. We've heard from some of the speakers about evidence. I just want to read you something from the Cochrane collaboration on this topic. So there have been 2 Cochrane reviews, one in 2014 and again 2 years ago. Key results. Combined results from 2 studies, well-conducted randomised controlled trials involving 662 people, showed that using an e-cigarette containing nicotine increased the chances of stopping smoking in the long term compared to using an e-cigarette without. More studies are needed to evaluate this effect. The quality of evidence is low overall because it's only based on a small number of studies, although the studies that were conducted were of high quality. They also mentioned that in the trials included, which ran for up to 2 years, there were no serious adverse events. The most commonly reported adverse events were mouth irritation and throat irritation. Now, I would put to you that we have drugs that are listed by the Food and Drug Administration in the US with much less than 2 years' worth of safety data. So I'm voting in support of this motion, and I would encourage everyone else to as well. Thank you.
Thank you. Microphone 2.
Thank you. I'm Mukesh Harkal. I'm a GP from Western Sydney, Melbourne. I just love Western Sydney so much I keep wanting to go there. So.
Well, as long as it's not green and leafy, you're all right, Mukesh.
Actually, it's exactly my point. It's certainly not green and it's certainly not leafy, but it's still very nice. It's very seasiding. I'd just like to make a couple of points. I actually have been quite involved in the tobacco discussion for many years of my life through this organisation. We have seen surprisingly large improvements of people quitting smoking, in particular young people taking up smoking. So much so that an organisation that I sit on the board of, Cancer Victoria, has had challenges and challenges and challenges by Big Tobacco to access the data that shows that plain paper packaging has actually stopped people taking it up. There is no doubt that there's at least $1 billion that has now been put aside by Big Tobacco to make this the way forward for them to continue to conjure their trade. The way to handle this and protect people who have problems with smoking, which, Rob, doesn't just happen in Aboriginal communities. It certainly happens in Western Sydney, certainly happens in Western Melbourne, it happens all around the country. And the way to do that is to use what we already have in terms of tablets, in terms of patches. But if we're going to use this, we could actually use this as a TGA-registered product. Actually give it as a medicinal product. So it's not banned. If it can be shown to be used and not be harmful or as harmful as tobacco, then you do it in a controlled way. And that way you actually minimise the harm and actually try and get people off the tobacco, which is the biggest problem that they actually have. The rates of smoking are much less here anyway, and other studies from the States and from here are showing that the government's probably got it right in this space. I know the Public Health Association of Australia would support me in what I'm saying, having spoken with them around this only last week. And I would actually oppose the motion as it's currently written. I think we can use these things in a controlled medicinal way using TGA, not open slather. Thank you.
Thank you. Microphone 4.
Thanks, Chairman. Roderick McRae, Public Hospital Doctors and Federal Counsellor. Just in great discussion, pertinent points on both sides. Could the mover of the motion in the right of reply please clarify if the intention in clause 2 of the motion was to include words along the lines of "in this marginalised population," and also, while it's a kind of a new topic, but what about support for a trial to actually test it out along the lines of what Dr. Heikewell just mentioned, but actually we will collect the evidence and take it forward.
Thank you. And last speaker, microphone 4.
Thank you, Dr. Sean Rudd, ex-smoker nearly. I just wonder how many people who've stood up and talked so far actually ever smoked. And it always reminds me whenever the first medication came out to help stop smoking. I can't remember the date now, it was some years ago. And I was talking to a colleague, this drug had been out for about 6 weeks, and she was waxing lyrical about what a great job and their patients weren't smoking anymore. And I said, 6 weeks, you've got no idea what nicotine is like. Nicotine gets you, and it gets you for your life. So the last thing we need to do is bring any more nicotine products. Now, we've heard various arguments, but we all do know that it will be the big boys in town who will produce this stuff. And nicotine is very, very addictive. I still, every time I see somebody smoking a cigarette, I want to take it out of their mouth and take a drag of it. Its smell of it, the want for it, it's there all the time. Nicotine is bad, full stop.
Thank you. I regret we've got to close off debate because we've got a right of reply. And Steve, if you go to microphone 2 rather than...
Just a point of information?
A point of information.
Well, it was just that very strongly it was quoted from the Cochrane Review and so on, and that would caught people's attention. But just to make the point, they say the quality evidence overall is low because it's based on only a few small studies, although these studies are more studies are needed. The whole point I was saying is we need to look at the evidence. The evidence is not there yet.
Thank you. Steve, your right of reply.
Okay, so what I would urge you to do is actually read the motion. It is a controlled introduction. I'm not advocating having a vaping shop round every corner. As a clinician, so I'm a psychiatrist, a public health physician, and an addiction physician, and I would like to have another means to help my patients. If you actually speak to smokers rather than lecture them, you will find that they actually regulate their nicotine intake highly selectively by breathing in more deeply or less deeply. Conventional nicotine replacement doesn't give you those peaks to actually monitor or manage your levels of nicotine. So some people actually do need e-cigarettes. People have talked about the harmful chemicals, and the aldehyde thing is the one that keeps on coming up. Actually, aldehyde is only released if the heating mechanism is too hot, and that actually produces a bitter taste. So people will be very unlikely to smoke aldehyde if they've got a bitter taste in their mouth. People have been going on about big tobacco. As I said, this motion is about a controlled introduction. we have been able to deal with big tobacco in terms of the sale of combustible cigarettes. So why can't we deal with big tobacco in the same way in terms of introduction of e-cigarettes, which are 95% less harmful? People have said about the Cochrane Review. The Cochrane Review only said that the evidence was poor because it was a small number of studies, but it was actually 600 patients. I actually work for the Advisory Committee of Medicines and the TGA, and I can tell you their drugs are introduced into Australia on the basis of safety and efficacy data. There are actually less than 600. So 600 is actually not that small a group of patients. People have said that Australia's got some of the lowest prevalence of smoking in the world, but that decline has arrested. And in fact, in New South Wales, actually the prevalence has gone up. And so therefore, there is a group of patients that we are just not reaching. And as I said in my previous remarks, we should leave no smoker left behind and leave them to be smoking a product that is way more dangerous than e-cigarettes. Also, people have talked about
10 seconds, Steve.
Need more trial data. We tried to actually run a trial in Victoria, but were unable to because it was so difficult to actually import
Thank you very much,
e-cigarettes into Australia. Please support.
Thank you. Okay, so you've we're ready to vote.
Just make sure their devices are woken up.
Make sure your devices have woken up with pressing any button. And voting is open.
Chair, why are we voting on these as not separate items as we did for the booking fees debate?
Well, because we've got a lot of business to get through, and it's a sentiment rather than, you know, as I said, these are advisory motions. They'll go to council and be thrashed to death. And this is the way they came to us. Okay, so the motion is lost. Thank you. Next speaker, and the topic is doctors dispensing pharmaceutical or other therapeutic products. The draft motion is that our AMA supports the position that doctors should not dispense pharmaceutical or other therapeutic products unless there is no reasonable alternative, and where dispensing does occur, it should not be undertaken for material gain. Moved by Dr. Chris Moy, seconded by Dr. Helen McArdle.
Thank you, Bev. Look, you need some background to this motion, which is that the AMA Ethics and Medical Legal Committee is currently reviewing the position statement on medical practitioners' relationship with the industry 2012 as part of a normal review. The policy advises currently that doctors should not dispense pharmaceuticals or other therapeutic products unless there is no reasonable alternative. Now, prior to 2010, the equivalent line in the policy included an additional qualification, which is that if dispensing did occur, that it should not be for material gain. The removal of the words for material gain in 2010 potentially opened the way for it to be acceptable for doctors to make a profit from dispensing. Now, the EMLC believes that this particular position places doctors in an actual perceived conflict of interest and recommends that the AMA return to a similar position and that we add material gain back to the position statement. Now, reinstating that doctors should not dispense for material gain would remove the perception and any incentive that doctors could profit from prescribing to patients, which is a clear conflict of interest. So this proposal is to some degree a return to a former position. Now, for the purposes of the policy, material gain is making a profit over and above recovery costs. The policy does not oppose dispensing altogether. It recognises there are legitimate situations where dispensing might be able to occur, such as in rural situations where there may be no access to a pharmacy. The policy, the issue at hand is about doctors dispensing on site. It's not about doctors owning a pharmacy for which we have a separate position statement. Now, delegates should also consider the ethical question and not the regulatory one, because keeping in mind that the regulatory definition of dispensing is far more than just handing out a medication. It includes things like preparation, packaging, labelling, record keeping, and the transfer of medications. So if we were to dispense on a widespread scale, it would actually require significant training and regulatory changes. Now, let's get to the nub of the argument to this proposal. And look, while I am the EMLC chair, I'm also a GP. So I actually do understand that many GPs feel under assault from different directions from pharmacists. And in the eyes of many doctors, this motion would be considered a surrender to pharmacists encroaching on GP space. I do understand there is seething anger that pharmacists have moved into vaccinating and providing sick certificates, and also that there's an indignation by individual doctors that, no, well, you're sort of questioning my ability to manage my conflicts. However, obviously the main concern about allowing doctors to dispense for profit is that they might overprescribe, potentially causing harm to patients. And this could undermine the quality use of medications, and just consider examples of opiates and antibiotics where we already have a problem with overprescribing. And this would put us in a position similar to health hearing centres, where the model of assessment and sale of product is inextricably linked, but which undermines any advice that they give. Now, there are examples of potential conflicts of interest when doctors have to recommend treatments in the consulting room, but prescribing in particular is something which is fundamental to what we do and frequent, and as a result has far greater scope for harm. But the nub of the argument actually lies in a recent position statement approved by the AMA, which is the AMA Guidelines for Doctors in Managing Conflicts of Interest in Medicine 2018, which says that doctors will face uncertainty when whether they have an actual perceived conflict of interest, and if so, what actions, if needed, need to be taken in response. A doctor should recognise they are ultimately not in a position to make this determination and should seek the advice of or delegate the decision to an independent party. Which means that at the point of care with a patient in front of you, you are not in a position to decide yourself, and you need an independent party to decide what to do with the conflict of interest. The problem is the patient is not the one you can actually go to. There is too much of a power differential, so you cannot make them the one to make the decision. Now, some may argue at this point that we would be able to manage this, but with ongoing pressures, time, repetition and fatigue, it would be easy to reframe the question and the conflict in your mind, and I'm not sure I could tell the difference after a while. And it would only take one proven instance of material gain leading to inappropriate prescribing and dispensing to seriously damage the trust in all doctors. Now, you may doubt this, but I think you need to look at another example of where trust is lost, and that's the Australian cricket team recently with the ball tampering affair. I mean, where we have one incident has irrevocably undermined our trust in the Australian cricket team. So to those who say that this motion would be a financial win to the Pharmacy Guild, firstly, we criticise and look down at them for their conflicts of interest, and I'm questioning whether we should be in a race to the bottom about this debate.
20 seconds, Chris.
And I believe we need to look past any anger to make clear by this motion that doctors should not dispense for material gain, because it's not worth the cost in terms of trust and a respected place in society for us to do so. Thank you.
Thank you. We'll ask the speakers just to come to microphones 1 and 2. I think that's a better use of our time. Microphone 1.
Omar Khorshid, Western Australia. I'm an orthopaedic surgeon, and I have to say I manage conflict of interest in my patient interactions every day. And whilst I accept Chris's point, I think I trust our members and our doctors to be able to manage the conflicts of interest. However, I'm still in support of the motion, because the reality is healthcare is delivered in teams, and it is actually in the patient's interest to have a pharmacist look at prescriptions, to look at, have another opportunity to look at other medications the patient may be on. Pharmacies are set up for the task of dispensing medications. They've got better security, better systems. Hopefully one day we'll get proper e-prescribing. It is a good healthcare system, and doctors just dispensing medication straight out of their back cupboard, in my mind, is not a good healthcare system. So I'm supportive of the motion, but I do trust general practitioners and other doctors to manage their conflicts of interest.
Thank you. Microphone 2.
Fred Beatros from New South Wales, a general surgeon. I do have an interest to declare. I was a pharmacist in another life. I support the motion. And the reason I do, it's not because I'm supporting pharmacy, but we can't have our cake and eat it too. And as Chris highlighted in his explanation of the motion, we take a moral high ground when it comes to looking at other areas of allied health and criticising when they try to encroach on our space. I think if we take that approach, we have to look at ourselves as well, and when that occurs, we need to be quite honest with ourselves as a profession. I do think we can handle a conflict of interest, but I agree that protecting the profession is, this motion would move towards that. The other point I'd like to make is that our own MGA just awarded our best paper for the year, looking at prescribing errors in hospitals, and it wasn't until the pharmacists became involved they showed a statistically significant improvement in outcomes with dispensing. So I think if we're going to advocate that as our best paper, we need to look at that evidence and take that on board when considering the motion.
Thank you. Microphone 1.
Dominic Barbara, GP, Victoria. I declare I have no intention of selling drugs in my surgery, but I do rise to oppose this motion. If we are looking for ways to lose more membership, this would be one of them. Pharmacists are prepared to give to customers whatever they like, including the so-called drugs which we feel are not really doing very much for the patient, such as cough mixtures and other things. So on the other hand, we have doctors out there who use complementary medicine, and I'm not one of those either, so I'm not doing it as a conflict of interest here. But I think we have to protect those GPs in particular who do use complementary medicine, and as well as being good GPs providing the usual orthodox treatment for patients. And by putting this motion up, we are actually cutting them out of what they're actually doing, and possibly doing, and I believe that they're doing some good, even though I don't use that sort of medicine myself.
Thank you. Microphone 2.
Simon Torvaldson, GPWA. I'm speaking here to oppose the motion, not because I oppose the intention of it, but more the wording of it and some of the issues that it raises. And I think that some of the previous speakers have confused the issue slightly, because we're not talking here about the desirability or otherwise of doctors dispensing. We're talking about the material gain provision. The current policy already states that we shouldn't be dispensing unless it's actually necessary, and in most cases it's not necessary, but there are situations where it is in remote areas and potentially in after-hours situations. So for those doctors where dispensing is a necessity, I think the fact that we have a clause that simply says for material gain actually is potentially threatening for those doctors where we talk about cross-recovery, but what's cross-recovery? It means that they're in essence feel obliged to dispense the medications for nothing, or to simply claim back the cost of whatever it cost them to buy. And I think that's a somewhat unreasonable burden to put upon those practitioners. If the motion said without undue material gain, or if it said something about the motive not being for profit, then I think that that would be reasonable. But in its current format, I think that for those small proportions of people who do have to prescribe, it represents a step backwards from the AMA in a practical sense.
Thank you. We'll stay with microphone 2.
Peter Maguire from rural WA. Just to follow on from Dr. Torvaldson's points, I'm probably one of the few people in the room that's actually done this. I have worked in a small town which is 70 kilometres from pharmacies in either direction, with quite a significant number of older people and no transport. My concern with I'm sure the motion will pass, and like Simon, the wording is my problem. Depending on the definition of material gain, we stocked a limited number of medications that really would not wait for a week for the pharmacist to deliver by road. So we didn't make, it's certainly not a money spinner, but we did charge what the pharmacy would have charged, which would actually fill the bill for material gain, because that is not the cost of the product, or even, because there's significant cost in setting up the labelling and on all the stuff that you've got to do to dispense. So I've got concerns about the wording. I'm sure it will pass, but I think when it does go to council, they need to be careful about that.
Thank you. Microphone 1.
Hi, I'm Kathy Hutton, a GP from Melbourne. I'm just worried about the wording in the motion, particularly probably the word dispense. So at the moment, GPs all around Australia will prescribe vaccination and charge for some vaccines, and we've got a big discussion going about wound dressings already. We just want to be careful that this motion doesn't stop us being able to do what we already do and is of great benefit for the patient. And I'm worried that the wording may do that.
Thank you. Microphone 1.
Andrew Pesher from New South Wales. Just to add a little bit of a different dimension to a lot of good points made, is it worthwhile considering PBS and prescribed medicines separately to complementary or sort of other non-evidence-based medicines which consumers can buy over the counter? They can order them online, get them overseas. It seems to me that pharmacists, their business model is to, when someone walks through the store, they just try and sell them whatever they want. But because it's not subsidised by the Australian taxpayer, it's tolerated. I don't think anyone admires it, and I'm glad I'm a doctor and not a pharmacist, because I think my business model is more ethical. But I think maybe there's just a worthwhile thing to consider there, that obviously doctors are often in positions of conflict of interest, as Omar pointed out. Fee-for-service medicine, proceduralist fees, we're all in a conflict when we decide what we're going to do for our patients. In terms of medications, is it worth thinking about PBS as a subsidising mechanism? So, using taxpayers' dollar to maintain income, that there should be a separation. So people who prescribe PBS should not be able to dispense it, whether that's doctors or pharmacists, except in emergency situations that have been highlighted.
Thank you. That's the last of the speakers. Chris, do you have microphone 2?
Look, just to the point about, really to yours, Michael, the issue is that we need to look at other situations where it's not just rural areas where this is going to be a problem, because the RACGP in the submission to the Review of Pharmacy Remuneration Regulation 2016 has opened up the issue about dispensing in after-hours situations. And we're going to create a big world in terms of, say, after-hours services, potentially prescribing, dispensing, and then you're creating a huge industry at that point. So, we are, and the pharmacies are not open at that point. So the material gain issue is very important. To the issue about the PBS, we have actually considered that issue, but the question I get back to is, do we really want to be to the race to the bottom? Because then we open it up to other issues. We have a conflict every time we're selling something at that point, and we're making material gain that actually conflicts what we do. And if we're starting to sell the best, I don't know, some very way out type sort of thing, and we're getting caught with that, it actually does affect our profession. And I think that's what this is about. You've got to decide what the cost is for the profession in making a decision here. We may lose a little bit in terms of profit, but I think we need to be better than that, and this is what this motion is about. Stay out of this area. Thank you.
Okay, thank you, Chris, and we'll wait for voting to open. It's open. The motion is carried. This will go to Federal Council for debate. Thank you. Next topic, and could the movers please move to the front row? Thank you, Roderick, as your time approaches. So Roderick McRae. Topic is supporting implementation of quality initiatives through entrenching the role of the profession and guaranteeing adequate funding. Do you want to read out your own motion, Rod?
I'd love to, but it's sort of way at the back of the room. It'll appear, and you have it on your papers. So thank you, Chairman. Like general practitioners, as we heard this morning, public hospital practitioners are actually now expected to also do more with less and less. All here are aware of the extreme reliance that's now placed on primary care practitioners to keep patients out of hospital. And it's very interesting to quietly reflect for a moment on who funds what and how. An aim is to avoid bad clinical outcomes. They're called hospital-acquired complications, or a HAC, which suggests the Russians are coming. There's a business approach, including Grattan Institute report on how to improve clinical outcomes. Terrific. So if you buy a widget, it has a price. And it's permissible to tolerate a poor quality to an accepted level. Business offers carrots. It drives incentives. There's trailing commissions, bonuses, and haven't they done the banking finance industry proud? There's permissions to clip the ticket. They're carrots. There's also, within the business environment, a stick. It drives penalties, and it's usually a price signal. Now, ostensibly, this makes a lot of sense if you're slapping a wheel on a car on a production line. But if you couple this with the absolute obsession from governments at all levels to cut costs in healthcare, it becomes a problem. Healthcare is special, given the impact on a citizen. The funding commencement point for public hospitals is essentially not quite enough or underfunding. You know about the increase in the population and the lack of increase in beds across physical and mental illness. You know about the increase in chronic illness, increased obesity, increased age. So it's very lovely to have a mechanistic, bureaucratic approach to this sort of issue and the funding issue of public hospitals. And it'd be lovely, we'll just get Hal to sort it all out for us. Terrific. However, it's a charade to dress all this up in an approach and badge it, label it as quality initiatives, when in fact it's a club to undermine already poor funding. To me, it's reminiscent of Clayton Utz' document retention policy related to the cigarette industry, which was really a destruction policy. Now, a recommendation from an inquiry into the Djerriwarrh Health Service in Victoria indicated good governance requires increased clinical input into governance and health service leadership. Hospital-acquired complications happen. They're not deliberate. They're not an ambition. They're pretty horrible to be hanging around when they occur. Yes to systems or root cause analysis, but no to penalties, which will make it harder to reach the nominal targets which will remain in place with less resources to obtain them. If you apply this concept to the corner milk bar, it will go bankrupt. For public hospitals, it becomes a financial death spiral for the hospital, and that is not in the public interest. We want, and the community needs, happy staff of an appropriate number and experience, well-resourced, in a happy work environment and good working conditions. That is the best environment in order to obtain good clinical outcomes. Thus, we require clinical input and leadership with proper resourcing, and it's crackers to accept a penalty program as there is a danger of cherry picking. Simply, it's about the patient, stupid. I commend the motion.
Thank you. The motion is that our AMA calls on all Australian jurisdictions to recognise that enabling clinical lead and providing adequate time and resources is the means to both improve public hospital performance and to ensure attention is not diverted from high-value care initiatives. And it was seconded by Stuart Day. Any speakers to the motion? We've got one. Microphone 1.
Thanks. I come from the state that decided when they were building the second most expensive public hospital in the world that they didn't need to ask the doctors. So as a result, we do have some room for serious improvement in how the hospital works and functions. They've realised their mistake. One of the things I did as state president of the AMA was reminded them of just this point. We need to actually respect the fact that people who know what they're doing actually know what goes on. And while we denigrate clinical leadership and put bureaucrats in charge, they don't always get it right.
Thank you. And another speaker, microphone 1.
Yes, I'm Kathy Hutton, a Melbourne GP, but also on the board of Western Health. And quality care is a very important thing to me, and obviously on our hospital board. And we're very, very clear that the way to get quality care, apart from setting in lots of systems with accountability, etc., is to support the staff, to support the staff that are doing the frontline work and make sure they're adequately trained, make sure they're adequately supported to be able to do their job, and make sure that the fact that they get up in the morning, want to come to work and do a good job, that there are not too many barriers in their way of doing it. And often the barriers are being overworked and just not having enough time to think about each patient individually. And I think making sure that that happens is where clinical leadership at the top will help to ensure that the frontline staff are supported, and in that way our patients will have a much better health experience.
Thank you. And microphone 1, and then
Xavier, you radiologist in a combination of public and private practice. I support the sentiment of the motion. The only issue I have with it is the wording, which I'd like recorded, is that whilst clinical lead is a rather ambiguous term, and I'd actually like to reinforce the comments that Dr. Fletcher made, was that it's actually doctors that have to be involved in leadership, particularly with these types of issues. We can try and advocate to delegate these roles to nurses, pharmacists, but you know, they're actually designated as clinical roles as well. But I would like to reinforce it's the role of the doctor to be very much involved in this. Thank you.
Thank you. Microphone 4.
Shanaz Salindra, Rural General Surgeon. I'd just like to be in support of this motion, but also add that the key is evidence, and we've been talking a lot about that today, and it's really very interesting if you look at how some of these penalty measures could be used in rural hospitals. My own hospital were able to challenge the NESQIP data, which is some of the big surgical data that sort of tried to show that we had a higher surgical infection rate, a longer stay and worse outcomes from gallbladders, and we actually did our own study and completely upturned the NESQIP data. So I think we need to encourage clinicians to not only be engaged but undertake an evidence-based approach within your hospital and to really focus on change management within your hospital that is evidence-based. Do the research, show the numbers yourself, and don't let big data take over and the government to enforce this on us. So I'm very much in support of the motion.
Thank you. And microphone 1.
Hi, Paul Bowett, paediatrician in Darwin. At the most recent Federal Council meeting, it was suggested by the current chair that I was getting too old for this because it was reported that I'd been part of a charge to save a bureaucrat from being sacked in the Northern Territory. And it was the first time I can remember in 40 years that I'd been involved with that. But the reason we got involved, and it was all the senior clinicians, was that this particular person really did take attention of the senior clinicians and listened to advice and really acted on it as best he could. And we were getting to a stage where we were going back to the bad old days where it was really top heavy with non-clinical lead people, and I think this motion is really important, and I think we really need to support it.
Thank you. That's the end of the speakers. Dr. McRae, you're...
Look, thanks, Chair. I sort of broadly heard support for the motion, which is very encouraging for this jurisdiction within the AMA. Dr. Yu's point is absolutely correct, so that'll be recorded and the language can be tightened up appropriately. And as often, it's all about the evidence. I still commend the motion. Thank you.
Okay. Thank you. So the motion will be ready for voting shortly. Voting's open. And the motion is carried. Thank you. Our next topic is pre-vocational research worth the CV paper it's written on. The motion.
Very good at puns.
The draft motion, our AMA calls on the learned colleges to ensure appropriate emphasis is placed on the importance of broad experience in a variety of clinical fields for selection into vocational training and correct the current overemphasis on non-clinical qualifications and courses, which is to the detriment of well-rounded trainees. Moved by John Zorba, seconded Chris Wilson. John.
So when you start working as a doctor, and in those first couple of years you're trying to get a handle for what you should be doing in your pre-vocational time to be a great doctor, what do I need to do to become a surgeon, a physician, a psychiatrist? And the answer you usually get from your seniors and colleagues is, don't be shit. Once you get past that and you look at the college entry programs and requirements, you're right, there's a complete myriad of hurdles and hoops that you have to jump over and through to enter your respective programs. Now, some with merit and some without. What we have currently is a complete mess that overemphasises non-clinical and non-worthy experiences. We have a system that distorts the workforce. And I've used this example many times. If you are a PGY3 resident in almost any hospital in Australia, and you're looking down the barrel of a PGY4 year where half your year is leave relief and the other half is nights, you're best served by quitting, leaving the profession, or leaving your training post, locuming at 3 times the cost to the health service that you just left, and completing a master's or a PhD that will have absolutely nothing to do with the clinical focus of the specialty that you want to enter into. So it does distort our workforce, and this becomes a problem for jurisdictions who continually tell me, we don't have enough doctors, you all run away on holiday, and we can't find you, and there isn't an oversupply and nothing's broken except that we don't have enough doctors. And I would argue that's the complete opposite. I would argue that we are forced out of the workforce by inappropriate selection mechanisms. It doesn't make you a better clinician. For all the letters at the end of my junior colleagues' names that outrank their senior colleagues, I don't see where these parts of research or university courses make them better at their chosen specialty. It does not make sense that you, by de facto, have to complete a PhD to become a dermatologist. Not all good dermatologists have PhDs, and nor should they need one. And it makes an incredibly terrible signal-to-noise ratio. We've created tertiary and quaternary hospitals and secondary services that have become cookie-cutter factories. In order to differentiate themselves from the pack, doctors in training complete courses and qualifications that every other doctor in training is doing. And all you have is the same doctors graduating with the same qualifications that are not relevant to their chosen clinical specialty. The current CMO, Dr. Brendan Murphy, is a champion for clinically relevant experience. I am a champion for clinical relevant experience, and putting this forward motion to the room, I hope that you are too. Thank you.
Thank you. Speakers, microphone 1. I am trying to get the speakers down to numbers 1 and 2, but those who have already set up shop are, are welcome to stay there. So, microphone 1.
Wayne Hurdy, General Practitioner. I have had the pleasure, the honour and the privilege of having taught a number of GP registrars, and I am appalled, with all due respect to the people up in the back row up there, who are very honourable people. They come to me with an incredible lack of clinical skills. I spend a lot of time teaching them simple stuff like how to give an iron injection, how to give a local anaesthetic for a suture, how to do a suture. The basic stuff they still don't have by the time they come to me, even in year 3. Why they would waste their time doing something which looks good on a piece of paper but gives them no practical skills at all is a waste of hundreds or even thousands of hours of time. I've got more letters after my name than most people I know, except maybe Rod McRae. I've done a number of degrees, I've done a PhD. It did not make a scrap of difference in my clinical skills. Get your clinical skills first, then go and do the fancy stuff.
Thank you. Number 1.
Gino Pecoraro, gynaecologist from Brisbane. I want to speak in favour of this. I've got a child who's a medical student from first year. She was saying, I need to get some research papers under my belt or I will finish medical school. I won't even be able to get an intern job, let alone a training position. It is ludicrous. It is absolutely ridiculous. I told her, well, how about you learn some anatomy and biochemistry first so that then when you come out you can be useful, and let's get some real life experience, work in the world so that you can be a human being as well as a doctor. In our college, when we rewrote the curriculum, much against my advice, it was mandated that a research component was put in. I think this is part of the area that we all need to get our junior doctors, our trainees, but also our seniors onto those committees and point out that there's nothing good about crap research. Not everybody is going to be a researcher. My forays into research taught me never for me. Clinical practice, love. Research takes a special person. If you want to do research, absolutely do it so we get good research, but forcing our junior doctors to do rubbish research so they can tick a box is counterproductive.
Thank you. Microphone 3.
Thank you. Chris Wilson, Deputy Chair of CDT, Basic Physician Trainee and RACP Online Exam Survivor. So I think we've got ourselves to a point where we've developed an arms race between doctors in training. And as Gino's quite rightly pointed out, those at the front end have now developed an advantage, because if you can get a master's while you're in medical school, you actually come out ahead of a service registrar who's been doing the job for 3 or 4 years. I'd like us to consider the impact that has on an individual, the time it takes outside of your full-time load to do research. You know, if it's your passion, that's great, but if it's to tick a CV box, then it's onerous. I'd also like us to consider in the spectrum of the renewed focus on mental health that we've had over the last 12 months or so, the impact that CV building has on people from a mental health point of view, from a burnout point of view, from a wellbeing point of view. And I think, you know, we really haven't seen much in the way of tangible changes yet for people pre-crisis. We've got the crisis side of things starting to sort out and evolve, but we need to move beyond awareness campaigns for burnout and wellbeing, and this is a tangible that we could change to say to the colleges, you need to step back and reflect on what you're requiring of your trainees. Thank you.
Thank you. Microphone 3.
Mark Orchard, Western Australia. Now I am standing in support of the motion, but actually to defend our learner colleges. I run a training program nationally, and let me tell you, selection is the least popular part of what I do as running that program. Nobody likes it. The candidates don't like it. My colleagues don't like it. But the reality is we have, this year, 229 eligible, that means jumped all the hoops, eligible applicants for 40-odd positions around the country. So there's going to be a lot of unhappy people because it is competitive, and at the end of the day, right now, merit is the only thing we're allowed to use. So we have to spread people out. You've got to create a normal distribution. And colleges in the past have been very lazy about how they do that. And not my college, of course, but some of them, you know, giving a lot of research, a lot of points on a CV for research is counterproductive for all sorts of reasons. However, research is important for everybody. And having just moved to a competency-based curriculum, we require everybody to develop the competencies in understanding evidence, because that underpins our practice. You can do it before training or during training. You can do it by real research or masters or whatever you want to do. Lots of pathways, but you've got to do it somewhere. What we did with selection is started to use some science. And what we realised was the CV is actually rubbish. The CV negatively correlates with other selection tools that are better. Negatively. So the better your CV, the less likely you were to get selected in orthopaedics. And that was because research isn't important, and it's because, or you know, the points that you get. And actually more experience is also not important. The more time you spend as a service registrar, the more times you've failed to be selected in the past. So experience per se is not enough. We've got to use real tools. For us, the evidence suggests interviews are where it stands, and so that's what we're beefing up. And now, if anybody wants to do orthopaedics, don't bother about your CV. It is worth almost nothing.
Thank you. Microphone 2.
Mark Kanguri from Perth, radiologist. I've had the pleasure and privilege of working in 3 continents, the UK, USA, Australia. And I must say, at this point in time, the trainees, as they come into vocational situation, have not been well prepared in their clinical acumen. They have lots of letters, they have lots of other bits and pieces, and I totally support this motion because what they are asked to do is absolutely meaningless. Now, in radiology, when I was selecting the individuals for a West Australian program, it was an interview, and if somebody came before the interview and he said, what should I do? I always said, more clinical jobs, so that you learn the clinical side of the equation, and then you will make a much better individual in your vocational training. So I think we need to go back and emphasize clinical acumen and not paperwork.
Thank you. Microphone 2.
Fred Beatros, New South Wales. I'm a heathen amongst surgeons when this was introduced years ago as part of the CV process, the research component. I strongly spoke against it. I truly believe research is what our profession is based on, but why in the world do we push the most junior people who have the least experience and input and views on health and disease to conduct research when you can get 10 to 15 years of experience under your belt, develop a meaningful opinion about disease processes, and then conduct meaningful research which will benefit our profession. The research for CV, in my view, is rubbish. I think we should be, there's so many doctors now fighting for positions. Our fellowship in the Royal Australasian College of Surgeons 3 years ago fell to the pass rate, our Part 2 exam, 55%. People fell down because they couldn't take a history and do a physical examination. They didn't fall down because they could quote the Cochrane databases and things like that. We need to be training doctors to be doctors first, and that includes being academics, but you can't have a good academic component to your practice unless you have some clinical acumen to back it up. I strongly support the motion, and I would encourage everyone else to do the same.
Thank you. Microphone 3.
Hi, I'm Alex Farrell, speaking for the Australian Medical Students Association. I'm standing for the motion and speaking to the very real impact this is having currently on medical students in the Australian system. Looking forward, we're very aware that the pressures to get onto vocational training places will only increase, and we're preparing for that. So looking at what it takes to get onto the specialty training positions, the current truth is we need research, we need masters, and students early in their careers are already beginning to accumulate those. So I've spoken to medical students who have not had a holiday since they began full-time medical education because they're doing masters in parallel, they're taking on extra research programs. This comes at a cost. It comes at a cost to our mental health. It comes at a cost to our ability to spend time with family and friends. It comes at great personal expense. And it comes at the cost of putting our time and investment into clinical education and what will make us actual doctors who can benefit the system.
Thank you. Just for convenience, we'll stay over there at number 3.
Thank you. I am Adam Castricum. I'm from the Australasian College of Sport and Exercise Physicians. Look, I'm strongly in favour of this motion. Look, we've actually changed our selection policy and reduced the emphasis on research significantly. We want to reward people with clinical experience. But other than everything else that's been said, which I strongly support, there are universities out there who are aggressively marketing to junior doctors about the need to, if you want to get on a specialist program, you need to do our courses. There's an instance that we're challenging at the moment, and we'd appreciate support on this, is that at Melbourne Uni there's a specialist certificate in sports medicine which is being marketed, and they shouldn't be doing that. They can have a master's, they can have a diploma, but you can't go out and say that you've got a 6-month, $6,000 specialist with medicine in it and say that will help you get into a program. It doesn't at all. So I think that those sort of behaviours need to be called out because it's not fair to anyone.
Thank you. All right, over this side of the room, so if anybody is wanting to speak, we're going to 1 and 2, but okay, number 2.
Thanks, Chair. Andrew Miller, dermatologist without a PhD. old school. Look, I arise like Omar to support the motion, but also to speak in support of the colleges. Some of us, particularly mine, have a real problem in that we have what is not considered to be any service component at all to our training. So there's actually no logical progression from a PGY2 to a dermatology trainee unless you do something to fill in those years. And it is of great concern to us as a group, and I know that it's also exercised the CPMC. What happens to those intervening years is people waiting to get into a training program and distancing themselves from professional growth. It is something that I think all of us need to be mindful of. The AMA has also been talking about these pre-vocational years, and I think we really do have to keep the pressure up. I don't see the colleges being the problem, though. It's actually the rostering practices of the major teaching hospitals, and like it or not, they're giving us the profile of the medical workforce of the future. It's got nothing to do with the needs of the community, it's just them keeping their turnover going, and we really need to be very strong. I think the profession has not just a responsibility to ourselves, but also to the community to take this forward.
Thank you. Microphone 2.
Brad Horsburgh from Brisbane. In a former life, I was the president of the College of Ophthalmology. By way of full disclosure, I have a child who is a PYG5. I get it. I know how hard it is for you guys up the back. It's terrible. And I support the motion, but there are a couple of things, 3 comments I've got to make. First comment. The push, the inexorable push for the PhD is producing journeyman candidates. Our candidates are not as good as they were 10 years ago. They do PhDs for reasons that I do get, everyone gets. But the very best and brightest go off and do something else. And we're left with good candidates who've done PhDs who are not necessarily the best candidates. Secondly, as colleges, we need to admit to the candidates that if they have had their second application and they have been unsuccessful, somebody needs to have a serious discussion with them about whether that's the way forward for them and are there other things that they may like to do. And I'm going to make one last heretical comment. It's taken the governments of both jurisdictions and both sides of the aisle 20 years to achieve what they wanted to set out to achieve, which was structural medical workforce oversupply. We're there. It is structural. It's not going away. At the moment, we're producing 3,700 doctors a year. We have a draining capacity of something like 24 or 2,500 positions a year. I'm here to tell you, guys, the Trans-Pacific Agreement has one upside for you. It could be very nice to work in Northern California or in Oregon. Go there, do 1 year and get on a training program and live a happy life and don't beat yourselves up. You're great.
All right. Microphones 4.
Thanks. Kate Langdon, and I'm a paediatrician without a PhD and a rehab physician from Western Australia, which is dry and not leafy. But look, I also have a daughter who's a second-year resident and another one in an assured pathway to medical school. And I wonder whether this motion will be enough to address the sense of ennui that we have heard from the DRTs and the medical students, because I think it is a workforce issue rather than something that you can persuade the colleges or the AMA necessarily to fully address. There is not only an oversupply, but if you go headlong into a vocational course that then goes offline or is exported with in due course to India or Asia, like most of engineering and law is now moving, you may find yourself needing that access to other skills in research and the broad range of training that you may have acquired en route into your vocational training program. So my personal advice to my own children is to do a broad range of training, do get into whatever course you need to get into, and I do appreciate that my life was much easier than theirs is going to be, but but I think that the workforce is going to continue to change so rapidly, and that we have enjoyed a bit of protected turf for a lot longer than our engineers and lawyer friends have had. But I don't see that you can necessarily protect this ground for much longer in the way that you would like. So on a personal level, I would train up as much as you can and embrace embedded research where you can get your hands on it. But I, in fact, support the motion.
Thank you. Microphone 4, 2 more speakers. Thank you.
I'm Georgina Taylor, rural GP trainee, and actually also planning on a career as an academic GP, hopefully if I can get the experience to do so. So I'd like to strongly support this motion, and I'd like to emphasise that a lot of the issue with this participation in research being required is that it's not currently supported. We don't currently have good clinical academic training programs in Australia like some other countries do. The UK, for example, has quite well developed programs that people can apply to from PGY2 onwards to get research experience during their work time as a doctor in training. And so I think that people who've spoken about the mental health effects and wellbeing effects of these sort of CV demands that are required of doctors in training, a huge part of it is because a lot of this is required in outside time. So in addition to your clinical work, your study, raising families, everything else that you have going on in life, you're also being expected to do this research and do these master's degrees. So I think that in addition to supporting this motion, that there shouldn't be this emphasis on CV building just to get into training programs, I'd also like to add that for those who have spoken in favour of research today and emphasising the importance of research, I don't think this disagrees with that at all, and I think that we should actually be calling for better integration of research and academic skills into doctor in training programs rather than as an extra that we all do at home when we get home from a long work day.
Thank you. Thank you. Last speaker.
Bev Manoharan, current radiology trainee, but previously a trainee of the College of Surgeons. And I guess my comments today are, I take what Dr. Khorshid said about the Orthopaedic Association on board, but they're targeted at the College of Surgeons and their ridiculous requirements for prospective trainees and in undertaking subpar and under-quality research. And I really just want to read an excerpt from a poster that was accepted and presented at the last College of Surgeons annual scientific meeting titled Research Quality for Junior Doctors, Room for Improvement. Now, the conclusion states, as evidenced by this poster, the increase in quality of research has not brought with it an increase in the quantity of research has not brought with it an increase in the quality. However, as more and more prospective trainees are attempting to fill the gaps in their CVs with research papers and presentations, there are exceptions. There are some good quality research. However, there is a lot of crap research amongst the endless dross, and this poster is an example of the dross. Now, this was accepted at the College of Surgeons conference, and I really just want to emphasize that there are a lot of trainees out there who will jump at any chance to do research, some because they're interested in it, and some because they need it to put on their CVs. There really needs to be an emphasis on the creation of clinicians, scientist-clinician pathways. We've tried that in Queensland, it works, but it is expensive and it requires funding from the jurisdictions.
Thank you. Oh, Dr. Khorshid.
Just a very quick point of information, just so everyone knows. The College actually of Surgeons is taking the AOA's lead and is actually looking at selection. It's held a conference recently, and I know that all the surgical specialists, they all do their own thing, but they're all now in this space and trying to do better at selection. And their motivation is obviously to pick the right people, to get a diverse group of people into surgery, and to make sure they're picking people who can complete the program. But I'm sure that as part of that, they're going to realise that silly prerequisites are not the way forward.
Thank you. And John, your final remarks.
I'd like to thank the room for the discussion. We covered a lot of territory. We discussed, the role of service and training. We discussed integration of research, and I'm glad to see that we were able to separate out clinical appraisal or research appraisal rather than research for research's sake. I am buoyed by the response of some of the colleges, but I'm not buoyed by the response of the majority. And this motion is directed to the colleges, and it is directed at the colleges is because the reason it is directed at the colleges is because when they tell me to jump, I say how high. and that is the case for every single doctor in training in the country. I don't think that doctors in training as a whole, reasonable doctors in training as a whole, are scared of competition. I don't think there is any doctor in training who has major objections to an open, fair and transparent system of selection. Yes, there are a lot of us. Yes, we all won't be able to get into our chosen specialty. But as long as the rules were there and the game was fair, I don't think we'll have a problem with that. And I think that's a reasonable expectation. What we're building at the moment is an environment in which exploitation of junior doctors for research's sake is starting to become the norm. It devalues research, it devalues our clinical work, and it devalues the profession. I'm glad for the support around the room, and I thank you for your time.
Thank you. So voting is open. The motion is carried. All right, we'll now suspend the policy debates and it's my pleasure to introduce Dr. Penny Brown from Avant Mutual. Dr. Penny Brown is the Senior Medical Officer at Avant. She advises the senior management team on all clinical matters and leads the team that advocates for Avant members to drive change in the medico-legal environment. Penny's worked extensively in general practice education, is currently a senior staff specialist in general practice at the Hornsby Hospital. Welcome, Penny.
Thank you, Bev. Thank you, Anne, Michael Gannon and colleagues. Look, I'm going to be brief. I know I stand between you and lunch, so I promise I won't take up too much of your time. I guess as the Chief Medical Officer at Avant, and as Bev has just said, I head up a team that leads the research, education and advocacy at Avant. And like the AMA, we want to really make a true difference in the practice of medicine for the benefits of our patients and the community. And as such, we've worked quite closely with the AMA and other medical stakeholders in a number of areas of common interest to us, such as promoting the health and well-being of our profession, particularly recently in relation to the mandatory reporting requirements, and also for better health systems of doctors. Today I want to say a few words about medical regulation. It's that labyrinthine area where policy and practice don't always quite coincide. Avant's role, obviously, as a medical defence organisation is to protect and support our members in the face of a complaint or a claim. One of the things that we're really concerned about is the significant impact for a doctor for being involved in a complaint or claim on both their personal and professional life. And this will continue in many instances long beyond the time of the closure of that complaint or claim, even for matters that are actually quite trivial. The advocacy efforts that we've taken to date and continue to do, is, apart from the regulatory, is really very much about some of the processes in relation to regulation, trying to improve the timeliness to reduce the pressure on doctors who are involved in complaints, to actually improve the early medical input into complaints so that it's actually not being determined by a non-clinician, that clinicians are involved from the outset. But today I wanted to alert you to a recent decision by AHPRA and the Medical Board, which I fear will make the impact of complaints against doctors even greater. In 2016, AHPRA and the Medical Board commissioned a review conducted by Professor Ron Patterson into the use of chaperones in sexual misconduct matters. One of those recommendations from the review was that AHPRA put on the public register. You know, if you look yourself up, or your future employers look you up on the AHPRA register, they can find your name, and they'll find conditions that you have placed on your registration. But now they're going to place on the AHPRA register a link under Dr. Penny Brown or whoever else to any tribunal or significant court rulings conducted by them. And this recommendation was not just limited to sexual boundaries, but to all judgments. AHPRA and the board have accepted all the recommendations from the review and are now in the process of implementing that recommendation. And we have some serious concerns about their interpretation and how this will affect the profession. In the new system, if a doctor receives a complaint and that results in a tribunal hearing, then that will be included on the doctor's individual entry, as I stated, and that will go back to 2010 when AHPRA came into force. So it's not just going forward, it's retrospective. So while this may be reasonable for reasons of transparency, where you can see where Professor Patterson was coming with his recommendation, we have two serious concerns about this. Firstly, the register will include those decisions where there have been no adverse findings against the doctor. So imagine it, you or me, we've been through the stress of a tribunal hearing, which I cannot emphasise how horrendous that is for our doctors, and finally the findings state, allegations not proven, it's over. You then try to move on with your life and later discover that there's a link that is placed against your name on the register. When the judgment states allegations not proven, what possible reason can there be for the judgment being linked to a doctor's name on the register, I ask you? Secondly, the other concern we have is that there's no time limit for the judgment to be taken down. In fact, there are no plans to do so. So a finding made many years before that has no relationship to the doctor's current practice or any conditions that they have, which have been well passed and dealt with, will remain linked to the AHPRA register in perpetuity. These two measures are deeply unfair. And I do not use this word lightly, but I actually feel they are also punitive. In addition to that, the communication from AHPRA about this matter has actually been quite confusing. We had one instance of a practitioner who misunderstood the content of a letter from AHPRA notifying him of the addition of the link to the register. And because of the reference to the chaperone review, he thought that he was now required to have a chaperone in his practice out of his confusion and horror when he first looked at the letter. For this doctor, and for many like him, the publication of links to their disciplinary proceedings will inevitably cause great distress and impact their careers as future employers look at it. I know that the AMA is also concerned about this decision, and under Michael's leadership have made representations to the medical board about it. I put to you that this decision is both unfair and, in my view, poor regulation, and we will continue to pursue this issue on behalf of our members. Thank you.
Thank you very much, Penny, for bringing this very troubling development to our attention, and we look forward to the work of Avant and other MDOs in this area. Thank you. So Anne's got a few housekeeping issues, and then we're going to break for lunch. We're in a bit of trouble. We hadn't expected you all to be so enthusiastic contributors on the policy matters, so I'll be speaking to you each over the break to see who'd like to take their matter off the table, or we'll be here all night. So.
Yes, indeed. It's been a good session this morning. Okay, so 2 candidate briefing sessions over lunchtime. Doctors in training, who I think might have already taken themselves off. The doctors in training are in the Cahoots Lounge, which is the Barack Obama photo lounge. And the ACT delegates, your briefing is in the ground floor bar area. You might like to get yourselves a quick bite to eat first and then go there, or take your lunch with you, given that you're a more contained group than the doctors in training. As the Chair said, lunch will be in the Eureka room where you've been having your other meals. If you want to present at the soapbox tomorrow morning, could you please give Lauren your topics and register with Lauren so that we have the list in advance of tomorrow morning? The Chair and I had hoped that we might make a little more progress than we've made, but we're clearly going to be running right up to the 5 o'clock shutdown tonight. 5 o'clock is when we need to go into urgency motions, and then in fairness to New South Wales delegates, they are the last of the candidate briefings, and it would be good if we could keep the urgency motion debates pretty crisp so that we can allow the New South Wales delegates to have their briefing and still have time to be ready for dinner. So with that, I'll send you off to lunch. Please don't take your devices with you, leave them on the desks, and we'll see you back here at 1:45.